Well, hello. My name is Stacy Davis, and I am with Metro Council. Metro Council, Metropolitan Council of Community Mental Health Centers is a collaborative membership organization representing the public mental health system of community behavioral health centers, serving the greater metropolitan Kansas City area. We provide support to our member organizations and education information and resources to the public on accessing quality health services. Every year, we host the Kansas City Mental Health Conference in May, as well as provide free webinars on the second and fourth Thursday of every month. In the chat box is the 2025 Kansas City Mental Health Conference registration link, which is on May 29th to the 30th at Johnson County Community College. It is $50 registration fee until May 15th. After that, it's $75, and you can earn all the CEUs for an additional $20. Just a reminder that the views and opinions presented are those of the speaker and do not necessarily represent the opinions of Metro Council. Please put your questions in the Q&A in the chat, and we'll address those at the end of the program. At the end of the program, I will also put a certificate of attendance link so you can earn your CEUs. I'm excited to introduce Rachel Bichara. She's going to present diagnosis and treatment of eating disorders. Rachel Bichara is the owner of a private practice in Kansas City called Curated Life Therapy. She graduated from Mid-America Nazarene University and is a licensed therapist in both Kansas and Missouri. Her specialties include treating eating disorders, OCD, and anxiety disorders. She's also passionate about educating other health professionals on recognizing the warning signs of eating disorders and knowing when to refer to a specialist to ensure best practice. Please welcome Rachel.
Hello, everyone. Well, I know I can't see any of you, but virtually waving. Hope everyone's having a good Thursday. So we'll just kind of jump right in. And I think we're going to be leaving like 5 to 10 minutes at the end for questions. So let's get started. So, as you know, we're going to be talking about diagnosing and treating eating disorders. These are sort of just like the formal objectives that I have outlined for this presentation. So wanting everyone to be more comfortable recognizing the symptoms and the different ways that an eating disorder can present because it can be so different from case to case. And then understanding like, why are they a big deal? Like, what are the short-term consequences? What are the long-term effects? That can occur. And then the last one would just be, for you to feel more competent and less nervous or anxious about working with this population, or at least to have the tools and information needed to refer as necessary. Okay, so I like to start out with just some facts and statistics about eating disorders. So I'm sure a lot of people have heard this fact before, but eating disorders have the highest mortality rate out of any mental illness. And that's typically because of the issues it can cause to the heart, and then also increasing the risk of suicide. Anorexia is the third most common chronic illness among adolescents. Eating disorders can affect any race, any ethnic group, any gender. Obviously, probably everyone knows that, but I think that there have been a lot of like stereotypes thrown out around time as like, oh, this certain group doesn't struggle with it, or that's not possible, but we really see them affecting anyone. And then genetic predisposition can account for 50 to 80% of the risk for an eating disorder. Obviously, that's not in every case, but there's a lot of studies done on genetic factors that have shown a pretty high correlation in some cases. All right, so some myths about eating disorders. A person with an eating disorder is not always going to be visually sick. We can't always tell just by looking at someone. I think most people would think someone who looks to be like underweight, that would be the marker for eating disorder, but it's not true. Doesn't have to really affect a person's weight. Sometimes it would cause a person to be not underweight, or maybe they'll be at like a normal weight, depending on what criteria you use. But yeah, not a good enough criteria to determine if someone has an eating disorder or not. Which is it does happen like in doctors' offices. Sometimes we see as long as someone's weight is within a normal range, it doesn't get addressed. So unfortunately. Stacy, I noticed somebody raised their hand. Are we pausing for questions as we go, or are we saving them all for the end?
Whichever you prefer.
Okay. I'm good with, I don't know how to let them talk. I just saw somebody like raise their hand. So I am not sure if somebody like put a question in. So I'm good with pausing to do that. If you want to find a way for those questions to get to me.
Or we can take that question at the end of your presentation.
Okay, sure. So I guess you guys write them down and we'll get to them later. So. Another myth is that eating disorder recovery basically just has to do with like getting weight restored, or getting it to a healthy range. And like it's so much more than that, like we're gonna get into later. Especially like sometimes I've seen cases where a person will get to a healthier place with their body physically, but the mental and emotional side of things is still very much thriving. And so it's definitely not just about that. Eating disorders are caused by the media. That one's a little bit confusing. Of course, yes, it is a factor, but it's not like it's only caused by that. I guess the point of this one was it's usually a large combination of factors. Eating disorders are not a lifestyle choice. Some people may choose to, have a certain lifestyle that, you know, maybe they're making certain like health choices that might resemble someone with the eating disorder, but it's not like if it is a true eating disorder, it's not just like someone choosing, it's something where they feel very trapped typically. And then, just because you see someone eating and acting normal doesn't mean that they don't have an eating disorder. And anorexia is also not the only eating disorder that's life-threatening. There is life-threatening aspects to a lot of other disorders that we'll get into. All right, so at-risk populations, obviously, like I said, it can happen to anyone, but we've seen like higher correlation in these population groups. So athletes, especially wrestlers or dancers, just because of the nature of that sport, can be very much like weight focused, especially with wrestling. Um, Routine dieters or calorie counters. I have the image on here of I can't remember what that app is called, MyFitnessPal, maybe something like that. Nothing wrong with that app, but for a person who has other risk factors already, it could be something that like pushes them over the edge into an eating disorder. If you're using it, it's totally fine. I'm just saying it can put someone more at risk. Someone who has like a more perfectionistic or type A, as we would say, personality, trauma survivors, and those with pre-existing diagnoses. I see some people raising hands, so write your questions down and I'll do my best to address them later on. Okay, so a few quick just like terms I wanted to make sure I explain before we get into some of the other slides. So whenever we're talking about eating disorders, we're talking about restriction. We're referring to like intentionally restricting the amount of food that you're eating or the type of food that you're eating. Typically, it's about the amount. Binging would be like a person, not overeating necessarily, but like getting to the point where they feel out of control around food. It's more than like you went out to eat Mexican food and you're really full afterwards. It's like a person, yeah, I don't know how else to describe it. I guess like it just feels like there's no control over what they're eating. They may even eat past the point where they're feeling uncomfortably full, feeling like really regretful afterwards. But the control aspect is a big part of it. And then purging or compensation, that would be any behavior, most typically it's going to be vomiting, but could be like the use of laxatives, could even be like intense over exercise, is what we're talking about. Anything done to try to compensate for the amount or type of food that the person ate. And then amenorrhea is like a medical condition where a person will stop having their menstrual cycle. And within eating disorders, oftentimes that's either due to like hormonal effects of malnutrition or different things like that, or it can be due to body weight being too low. And then body checking. Whenever we talk about that in eating disorders, we're talking about like kind of like fixating on certain parts of the body, like spending a lot of time in the mirror or like physically analyzing a certain part of the body related to like body image distress. Okay, so good old DSM-5. Getting into the different diagnoses, I won't like read these line by line, but anorexia, probably the one most people know the most about. It has to, in the DSM, it still requires that that person have a low body weight, which there's more specific criteria in there. Um, and then intense fear of weight gain. So there's different types you can see there. Um, we'll see a little bit later in the DSM, it's called atypical anorexia, and it does not have the low body weight requirement. I don't like this. I think it kind of continues the stereotype that a person with anorexia is always going to be underweight. Um, but it's just the way that it is, and there's a diagnosis for both cases, so we can get the help that people are needing. And then bulimia, binge eating, and some type of behaviors to compensate for the binge. Um, those behaviors have to occur at least once a week for 3 months. And of course, it can be a lot more than that as well. And usually the driving factor behind that is body shape or weight. And then this is just a graphic of that binge and purge cycle. I think it's helpful. Um, honestly, I like to think of it as starting at number 5, like the strict dieting. So a person decides they're going to go on a diet because they're unhappy with their body or whatever's going on. At some point, there's going to be too much built up tension and cravings. It's going to lead to a binge. After the binge, they're going to be concerned again about losing weight. So purging is likely to happen. And then we have feelings of shame, disgust, all different types of emotions there, which will probably lead them back into that same cycle because now they have to do something about those emotions. So it kind of can just become something that a person gets really stuck in. So I thought this was a helpful visual. And then similar here to the graphic down here, it's kind of like the same situation. So binge eating disorder, this would be where a person is not using compensatory behaviors. So binge eating, like I said earlier, eating rapidly until uncomfortably full, um, eating when not hungry, eating alone intentionally. Obviously, everyone has probably eaten out of boredom before, but this is like to a different level and kind of there's all these different criterias that have to be there. And then avoidant restrictive food intake disorder. Um, this is different than the other ones. It's when the main issue has to do with like the sensory, some type of sensory characteristic of the food. I've seen this happen in cases where a person maybe like got sick after eating a certain type of food, or they have like food allergies or things like that that just cause a lot of fear around food in general, even foods that they're not allergic to. So this one can become something that, requires like hospitalization if they're not able to eat enough. And it has a lot of, psychological consequences as well. Orthorexia. This is not in the DSM. It's usually would fall under the category of ARFID. It's kind of like a newer, I guess not too new now, I guess the 1990s. So it's been around for 30 years or so. But it'll have to do with an obsession around like only eating certain foods, like really checking ingredients and labels. And not that there's anything wrong with like understanding what goes into your body, but this is where like to that person, it feels like it's taking over their life. It feels like obsessive. They're not able to enjoy like any foods that aren't on their safe list. Usually it'll start out with cutting out something small, and then sometimes it turns into like whole food groups, or maybe this person only has like a few foods that they feel comfortable with. And sometimes this could be more like OCD related or more anxiety related and less to do with body image. So that's why I put at the end, like sometimes body image concerns aren't really present. It could be caused for different reasons. And then, like I mentioned earlier, the atypical anorexia is there. Bulimia nervosa with lower frequency. binge eating disorder with lower frequency, and then purging disorder where there are no binging behaviors present. So there's lots of different types of eating disorders and ways that they can present. And so I thought it was good to just include those. Okay, so um, I just wanted to include this. I know I kind of mentioned earlier some um, ways that eating disorders don't always get noticed. So some commonly missed warning signs, of course, these don't have to mean that a person has an eating disorder, but they could mean that. So if a person's having an irregular period, that could mean that it's a warning sign of a eating disorder. Severe constipation can be a sign of eating disorder. Isolation after meals, like if a person's always like disappearing after they're done eating. Again, these things could mean nothing or nothing eating disorder related, but they could also be something that if we don't know like what questions to ask, we could miss the correlation. So like a person's, constantly dieting, cutting out whole food groups, um, going vegan, gluten-free, those things can be for other reasons, like I said, but if it's easy for the eating disorder to use that as an excuse to just cut out more food, basically. So I've seen that happen quite a bit, where there's not really like a dietary concern. It's more of just like a reason to limit certain foods. Um, so yeah, those are just some things that we can be on the lookout for. We can be asking about if there's already other concerns. And then comorbidity, wanted to definitely talk about that. Eating disorders often occur with another mental health diagnosis. I would even venture to say that they always do. It's strongly recommended that we treat both. So if a person has like OCD and an eating disorder, we only treat the eating disorder. Sometimes then the OCD is going to take off, or sometimes recovery from the eating disorder isn't actually going to be effective until we treat both. So in some cases, if the eating disorder is quite severe, we do have to address that first in order for us to see improvement in other areas. But I just thought it was really important to include that, we need to make sure that we're screening for other disorders as well, so that we're kind of treating the whole situation. All right, so we'll get into causes. So as I mentioned earlier, there's a lot of genetic biological factors. So this feels like hard to believe, but I've read this in multiple different studies. If a person has a first degree relative, so that would be like a parent or a sibling, not like an aunt or a cousin or anything like that, they're 7 to 12 times more likely to develop an eating disorder themselves. Twin studies prove just significant ability to inherit eating disorder factors. Of course, we could also say if a parent has an eating disorder that's untreated, then likely they're going to expose their child to a lot of the same environmental factors that cause their eating disorder. So that could also have something to do with it for sure. But if a person has, and this is true with any mental health disorder, if there's a genetic predisposition and then triggers also happen, it's more likely to lead to a disorder. In a case where someone didn't have genetic factors, they could maybe go through some of the same triggers and not lead to a disorder. So there's that. And then cultural factors. So certain cultures maybe emphasize body image and weight more than others, or they emphasize them like in different ways. Like there's a different ideal in different cultures. Sometimes people assimilating to new cultural norms that they're not used to as far as body image can be really triggering. Family members commenting, not just family members, but family members or friends, whoever's in that cultural group, commenting on each other's weight, like in a playful way, even they might not know like how that's actually impacting the person. So, I put like a list here of like some comments that probably some of us have said or at least heard, that like you're not trying to do harm, but if you don't really know like the person's situation that you're talking to, it could, like if you're telling someone like to suck in their stomach and you don't know that they already have been like obsessing or fixating on their stomach, um it could just make that much worse. So I think it's good to just be cognizant of that, of not overly commenting, really, in my opinion, commenting at all, on other people's appearance or like their eating behaviors. Just because like we don't know what it might be causing in them, or what it might be intensifying or accelerating. I think I've had a lot of patients who will, of course, it's not like one comment causes eating disorder, but they'll have like a few like core memories of times where, someone commented on something that they were already feeling insecure about, or maybe they weren't even thinking about it and this person made the comment and it really stuck with them. And like I said, it doesn't like cause the whole eating disorder, but if enough factors are already there and then this happens too, we can really like fast track a person to that. All right. So another factor, social influences or learned behaviors. So more is caught than taught. I'm sure we've all heard that phrase. Sometimes it's used in a good way and sometimes in not so good way. So um, even if like a parent or caretaker isn't like directly like telling their child like that they need to lose weight or something, like watching the adults in a child's life constantly talking about their weight or always talking bad about their body, like that is something that we can pass on to a younger generation without even really realizing it. Or like constantly talking about like how many calories are in things in a not helpful way. um, Maybe you're not trying to pass it on, but it can be a behavior that others will learn. Maybe not even younger generation, it could just be like your peers. Harmful language around body and weight, like I said. Dieting tends to be a pretty common trigger for eating disorders. Maybe it starts out as just a regular diet. But if that person, like we said, if they have enough underlying risk factors already, that diet may not be something that they can just do for 5 days and then walk away. Um, 52% of Americans will diet at least once a year. That was in 2022. I would imagine it's probably more than that. Um, Although I do feel like we have been making progress, as a society in pushing it less. Of course, it comes out in other sneaky ways that aren't as obviously a diet. So, and then a staggering percentage of children will diet before age 10, which is so crazy to think about. A 10-year-old thinking about this. But again, I think it's being exposed to the idea and, thinking that's a good thing to do and maybe it will be fine for them, but it could also turn into something later on. Um, all right. So I put just kind of like on the note of, like media, social influence. These are just like some graphics I found from online that are obviously talking about some really like sensationalized diets. This one's like really crazy. How was it even allowed to be published? It was from 2009. So sort of like the social pressures and like that feeling of desperation that a person might get to when they're unhappy um, with their body can something like this can really affect someone who's in a vulnerable position already. Okay, so back to different causations. So, life stressors, so trauma of any type, whether it was like from the past and it's unresolved or recurring, something more recent, grief and loss. I always say, like, even after a person has recovered successfully from an eating disorder, kind of similar to how um, AA might explain alcoholics. I, at least from my understanding, the sort of like basic understanding there is like you're always an alcoholic. You could always go back to it. It's never something that like you couldn't struggle with again, even when you are like in sustained recovery. I really feel like eating disorder is very similar, where if you're going through something like grief or loss or just like a really tough transition, the eating disorder could be there like lying dormant and it could be ready to like, be used as a coping skill again, unfortunately. So it's something that we kind of have to like be aware of even in sustained recovery. Poverty or food scarcity, life changes, body changes due to all sorts of different things. Diet culture, if a person already has low self-esteem, um, and then unrealistic expectations, pressure from others and from yourself. I think there's definitely a narrative in diet culture talking about like if you want to weigh a certain amount or you want to look a certain way, like there's no reason why you can't. There's nothing stopping you but yourself. And I just don't believe that's true. I mean, scientifically, genetically, but diet culture does a really good job of putting all the blame on the consumer. Um, if it doesn't work for you, nobody really goes to Weight Watchers or whatever and complains to them that they aren't losing weight. It's something that a person will internalize most of the time. So it can just become really toxic and destructive to a person's self-esteem. So health complications. These are more short-term ones. They're possible health complications. They don't always happen. Um, Interestingly, like eating disorders can actually slow down a metabolism. So restriction is the number one cause in this circumstance of having like a slower metabolism. So it'll actually cause people to feel less hungry. Their body starts to ignore their hunger and their hunger cues and can just like lead to more and more restriction. Or they're having a hard time eating because their metabolism is so slow that after a while of restricting that their body's just like not digesting things normally. I also mentioned like constipation earlier, that's related as well. Um, all sorts of different things here that can happen with different eating disorders. So dehydration, esophageal damage, electrolyte imbalances. We see those more commonly whenever there's vomiting or some type of purging behaviors happening, because that does lead to, just that person not having enough fluids. GI issues, hair, skin, and nail issues, dizziness, trouble standing, obviously like lower blood sugar, maybe lower blood pressure, brain fog, and trouble concentrating. So these are some, not all, of the shorter term complications that can happen. And then as far as long term, like I mentioned earlier, amenorrhea, so it can cause disruption to a person's menstrual cycle. Bone density loss. This is one of the only damages that can be irreversible. So most of these things, like once a person gets healthy, or with the right treatment, they can recover from that health complication. With bone density loss, if the bone density is lost within a certain age range, um, usually like the early 20s, it's not really possible to like fully regain all of that bone density that was lost. So it's unfortunately not something that's particularly convicting to like a 16 to 18-year-old that might be struggling with this, but I mention it to my patients because I think it's so important. By the time they get to an age maybe where they are able to see it as more of a concern, it could be too late to fully recover in that way. So organ damage, so damage to the heart, intestines, liver, I mean, it can affect all different types of the body or all different places in the body. Muscle damage or loss, kind of similar to the bone density loss. Bradycardia, that would have to do with irregular heartbeat. And then fertility issues can also be something that is caused by eating disorders, especially if it's affecting the menstrual cycle or affecting hormones and things like that. And then intensification of any other issues that are already going on. All right. And then as far as like social consequences, what I see a lot, isolation. Eating disorders thrive in secret. COVID was a really tough time for lots of mental health things, I'm sure, as everybody knows, but especially eating disorders. When you're alone, nobody is there to hold you accountable. You don't have to go eat meals with your family. It's just a lot easier to get away with behaviors, with eating disorder behaviors. Could lead to like job loss or dropping out of school if a person is, not able to concentrate or just feeling physically sick, often just missing too much work or school. It can really impact their life in that way. Inability to maintain relationships. One of the difficult things about eating disorder is that you can't just stop eating to get over it, like with obviously drug and alcohol addiction. Not saying that that's easy to recover from by any means, but this is a bit different where we can't just eliminate that substance from our life. We have to continue doing it. That's the whole point of recovery. So it can be difficult, especially like with relationships. A lot of things revolve around food. Like, let's go to dinner together, let's have a family meal, let's, go to a buffet or whatever. So it can cause people to start turning down social connections because of the fact that it involves food, and that just feels too much, too much for them. Let's see, kind of talked about some of these already. Losing one's identity or their authentic self, hurting relationships with loved ones because maybe they're not being honest if they are checking in on them. Um, I used to have a slide in here. I kind of cut it down a little bit since we didn't have as much time today, but I really view eating disorders as having a lot to do with connection to others. Sometimes, if we increase the connection with others, we're seeing an improvement in the eating disorder simply because now we're rebuilding those relationships. We're healing some of those things that have been, I guess, broken before. A lot of the time, when a person is feeling isolated, eating disorder is something that gives them a sort of like a sense of connection to something, something to focus on. So, um, a lot of times, like if a person's in a treatment facility or in recovery, involving family, involving relationships, involving support system, loved ones, they may not always like that in the beginning, or their eating disorder doesn't like that, but it can be really invaluable. All right, so wanted to talk about some different levels of care. So we've got acute and inpatient. So main difference between these two, acute care, that's when a person is, they're just not medically stable enough to go to a treatment facility where there's not 24-hour like medical supervision. So focus there is going to be getting them medically stabilized to the point where they can go to a step down. Inpatient is going to be appropriate for patients that may have severe co-occurring disorders. Still, they're going to have 24-hour supervision. This is going to be like a hospital setting or maybe a treatment facility specialized for eating disorders. There's still going to be some medical complications that need to be monitored. And so these two levels are like the highest levels of care, that hopefully, won't be super long. But the goal would be just to get them stabilized to where they can continue working on their recovery. And then residential. Um, I know we have lots of questions coming up here, so we'll get to those at the end. So residential would be, again, 24-hour supervision. A lot of times this is going to look like a patient going to live at whatever facility. I think maybe we have someone from this place with us today, but I don't want to say the name of it wrong. But I know there's a newer eating disorder treatment facility in Shawnee, and I think they might have residential. I'm gonna have to verify that later. But that's the only place in town that I know of that possibly has this level of care. So once a person has made a lot of medical stabilization, a lot of headway in that area, they might be more fit for residential care. So they're responding to weight restoration at this point. Intensive therapy is going to be happening, efforts to reduce the eating disorder behaviors, and then dietetic and psychiatric services will be on site at that point. And then we'll have partial hospitalization and intensive outpatient. So we do have a few different facilities here in Kansas City that at least offer intensive outpatient and some that offer partial hospitalization. So it's going to look different depending on the facility, but typically it'll be 5 to 6 days a week for 7 or 8 hours a day. There's a lot of supervision happening. People aren't going to the bathroom by themselves just in case there's any like purging behaviors happening. 2 to 3 supervised meals and snacks per day. So someone is like making them a meal plan, preparing their meals for them, just to eliminate a lot of the struggle with figuring out what they're supposed to eat, when they're supposed to eat, things like that. Um, Individual, family, and group therapy is going to be a part of that. And then again, dietetic and psychiatric services will be on site. Usually there's going to be a doctor or a nurse monitoring vitals, making sure that they're remaining stable or referring them back up to a higher level of care if needed. So it can be normal for a person to have to go to treatment multiple times or to go from, um, residential care to all the way back to outpatient and then to have to go back up if their symptoms aren't getting better. And then obviously outpatient care is what I do. So meeting weekly or biweekly, depending on where they're at in recovery, that would be like the lowest level of care. Maybe we should, I don't know if we should wait till the very end for all the questions. I was wondering, Stacy, if I could look at a few of them, just because I don't want it to get like too far into where I forgot what I was talking about. Maybe we could pause for a minute and take a
Sure.
couple.
You mentioned partial hospitalization locations in KC. Do you know what the names of those are?
Yeah, so for sure, ED care, they have partial hospitalization. I can't think of the name. I think it's Center for Discovery or Center for Change. I could be completely wrong. The new one that just opened in Shawnee recently. I can look it up afterwards, or maybe somebody here works there. That would be great for them to jump in. But I believe, oh, I see some chats happening. I feel like somebody knows. Those are the two that I know of that have PHP. Because McCallum Place, unfortunately, they're no longer here in Kansas City. What else do we have?
Have you worked with a person who does not have a low body weight who is restricting? I've heard that this is becoming more common and more of an atypical presentation of anorexia.
Yeah, I think it's super common. Some people are not going to respond to restriction with like a significant amount of weight loss in a rapid amount of time. So it's going to be missed by some of that criteria. So definitely, especially if it's sort of like cycles of restriction, um, definitely it's something that I think happens quite a bit. Yeah.
Okay, why don't you go ahead and continue? Oh, I'm in Southeast Missouri and I'm unaware of any local or even regional resources for supporting clients with eating disorders. Is there anyone aware of treatment options south of St. Louis?
I know there's options in St. Louis. I know McCallum Place is there, and I believe Alsana might be at least nearby. Someone fact check me on that later. Okay, I'll go ahead and continue and then we can jump back into these. Thank you. And I think somebody had their hand raised. I don't know if everybody can see that on their screen or
Yeah,
not.
we'll address that in a minute,
Okay.
Rachel.
Okay. Alrighty. So treatment options. So what I feel like is ideal, not always possible, especially when it comes to insurance, combination of therapy, medication, nutrition management, medical supervision, and lifestyle adjustment. So I always require as much as possible that my patients go as soon as I start working with them and there's some level of eating disorder concern, that they go to their doctor or find a primary care doctor or go to Quest, whatever, and get just like general labs done just to make sure are they medically stable enough for outpatient. That's really important, if you are an outpatient provider, to make sure that this person is fit for outpatient care, from a medical perspective. So just having them run general labs, there are more specific labs that you can check for eating disorders. If they feel comfortable telling their doctor that they are struggling with disordered eating, even better, because they will then know like what other things to check on. But anyways, that's really important. Let's see, medication is not always something that's going to make a huge difference for them, but just seeing if that's something that's needed or if that's something that makes a difference, I think is really important. So yeah, weight restoration can be a key component. It's not always. It also, like, just because a person gains 15 pounds back and they're back to the weight they were before doesn't mean that they don't have an eating disorder anymore. In fact, sometimes people will like comply with the weight restoration just to, like, get you off their back, so they can go and lose it again or go and like let the eating disorder thrive in some other way. So, it can be really important, especially for medical reasons, but there are so many other factors. Um, Again, we got to make sure that we're addressing all things that are going on with their mental health. There's a couple of different modalities here that I think are really beneficial, very useful with eating disorders, primarily CBT and DBT. Those are going to teach just a lot of really practical coping skills, which is often what a person struggling with eating disorder really needs. Like, how do they deal with this thing that's yelling at them, telling them, you know, what to do when it comes to food and exercise and things like that. So giving, excuse me, just really practical coping skills, I think is key. And then maybe looking into other types of therapy later on, especially if there's co-occurring things. Do they need trauma therapy? Do they need, EMDR, addressing all of that? Some common treatment goals might look like, again, weight restoration sometimes, or like stabilizing, finding body acceptance, um, dealing with any relapses that might happen with eating disorder behaviors after weight gain happens. That's something that's really common, helping them deal with like their changing body when they've been working so hard to keep it the same for so long. Consistent meal plan compliance is very important. Usually when I'm working with someone in outpatient, they're also working with a dietitian, a dietitian that is eating disorder focused, and I have some great referrals for that if anybody needs them. And um I'll work with them, collaborate with them just to make sure that, we're both catching things and staying on the same page. Um, Sometimes this isn't always important, but if a person is struggling with like over exercise or compulsive exercise, sometimes we need to reduce that in the beginning stages of recovery at least. The goal is to help them have a healthy relationship with movement, but sometimes that requires just eliminating it for a period of time. Implementing healthy coping skills, reducing eating disorder behaviors, increasing self-esteem and social connection, identifying triggers and planning for relapse, making a plan in case relapse happens is really crucial. So I always say like relapse or slip ups, I guess, they're going to happen. So knowing that they're going to happen, knowing what might cause them to happen as you get to know your eating disorder more, and then making a plan like, okay, once I start to notice this warning sign, I'm going to do X, Y, and Z. Or if I start to notice this symptom, I'm going to call my psychiatrist or my doctor or whatever. I think that's a really powerful part of recovery and a part where we can really empower them as well to understand, when do I need to ask for more help? And when am I managing this okay? All right. So I just put a little bit of information here about psychiatry. So medication is often necessary for recovery, especially in the beginning. If a person's dealing with a co-occurring disorder that is just too intense, they're probably not going to be able to simultaneously tackle intense anxiety or depression and this eating disorder at the same time. So sometimes medication is going to help sort of like jumpstart them into that process. So that can be really important. It's great if this is not always as practical, but it's great if you can work with a psychiatrist, collaborate just like you would with a dietitian. I know sometimes it can be harder to get a hold of them because they're so busy and in such high demand. But that anytime we can collaborate with doctor, dietitian, psychiatrist, going to be better. And then some medications can have negative effects for patients that are suffering from bulimia. So because of the dehydration factor, because of the purging, it's just important for a person with bulimia, for their psychiatrist to be aware of that so they can make sure that the medication is going to be a good fit. And then again, considerations for medication, just making sure that we are letting the doctor know what, or the psychiatrist know what eating disorder behaviors are happening, because there can be things that can be intensified by certain types of medication. I mean, this is true with anything. It's always good to make sure that a doctor or psychiatrist knows everything that's going on medically. So, it's really important. I see this a lot, fear of taking medication because of the stigma or stereotype that it's going to cause weight gain. Um, Sometimes that can be true. I don't think that it's true in every circumstance, but I think it's like widely known or widely held that that can be a side effect of different mental health medications. So I've definitely had to work with patients on like overcoming that fear so that they can get the relief that they need. And then as far as like different types of therapy, so Individual therapy is going to be crucial. Again, addressing comorbid issues, and this is like if they're appropriate for outpatient care. Identifying triggers and developing a relapse prevention plan, involving family, even if it's not family therapy or couples therapy. I even sometimes like will just have mom come in for like part of the session or have a partner join for one session just to help that patient like clearly communicate, here's what I need for support, or helping address whatever we can to make that support network the best that it can be. And then I mentioned dietetics. So a dietitian, so this first point, it's kind of more about like really, really severe eating disorders. So it wouldn't be something that would be handled on an outpatient level, but certain foods can be harmful in the beginning of recovery. So it's important to keep that. It's important to make sure that you're consulting a dietitian and not just like trying to make suggestions to the patient yourself. Communicating with them about portions and exchanges, that's something that the dietitian would do, helping them understand like what's an appropriate portion size, what types of things should I be eating, what makes like a full meal. This is not my area of expertise, but just to give you an idea of why that's so important. Um, Especially if a person has been restricting for a long time, like the idea of suddenly like having multiple meals a day and figuring out what to put in them can be so overwhelming that they don't even try or they just shut down. So this can be super, super helpful in that case. Um, and then, yeah, the dietitian will kind of stay in charge of increasing or decreasing that meal plan. Usually they'll be weighing the patient when it's an eating disorder focused dietitian, they'll be weighing them each time they meet or once a month or something like that to kind of track the progress in that area. And then, of course, the therapist is tracking the progress in other areas. I put this graphic here just to highlight the importance of making sure that this dietitian that you're referring people to is an actual like eating disorder focused dietitian. Whenever I was looking for like graphics about dietetics, these are like all the top ones that came up. So it's like fruit and vegetables and like weight measure or like the measuring tape. Totally fine. Like this is a part, it can be a part of dietetics, but I think it's important to make sure that they're not going to be going to see someone who's going to be encouraging them like to lose more weight or helping them lose weight. We want to make sure that we're going to someone who has an expertise or specialized training in eating disorder recovery. And then I added this slide. I know we're kind of getting close to our time here, but behavior swapping is a phenomenon that I think is important to keep in mind. So sometimes like they'll stop one behavior, but it might be because they're switching over to another one. So maybe they stopped restricting, but what you don't know is now they're exercising for 2 hours every night. So just knowing that we want them to move to like healthier behaviors, but trying to keep an eye out for, are they just using some other behavior to attain that same goal instead? So like knowing what questions to ask. Um, and then, oh, sorry. Some helpful interventions here. Meal support is a big thing that kind of like blew up during COVID, which was great. A lot of people were hosting like online like meal support. Like they'll eat a meal with you while you're at home alone, so that you have someone there with you. So you're not, feeling too intimidated or whatever, like just accountability, I guess is what I'm trying to say. Again, addressing underlying issues, support groups, incorporating family and friends, lots of different ideas here. I won't go too deep into. There's also a lot of really great online support groups as well, if like location is a difficulty. Let's see. Okay, sorry, I was going to see how much time we have. So, values clarification. I think this can be really important. This is a part of acceptance and commitment therapy that I mentioned earlier. So, having eating disorder clients go through acceptance and commitment therapy, or at least like borrowing concepts from it, can be really important. A lot of times when someone's been living with an eating disorder for a long time, they like lose their identity. They don't know like who they are outside of the eating disorder. So helping them separate their authentic self from their eating disorder is going to be really important. And ACT can be really helpful for that. Um, when to refer to a higher level of care. So if you're seeing someone on the outpatient level and they're no longer really complying with the treatment plan, they're not trying to reduce behaviors, they're not seeing the dietitian anymore, um, I think that's the time where you need to push for, let's look at some intensive outpatient programs. Let's at least like do an assessment at wherever. Um, if you're noticing, obviously, like they're getting worse, their symptoms are getting worse. Um, if you're noticing like any like self-harm or suicidal ideation in connection with the eating disorder that you don't feel equipped to handle, um, if there's any increasing medical concerns, and of course, like if you don't feel like you have the expertise to treat eating disorder, you can always do consultation. That can be really helpful, with other professionals who do specialize in this area. But I think there's no shame in referring for anything that's outside of our scope. So keeping all that in mind. And then where to refer. Okay, Center for Discovery. I knew I had it in here somewhere. So I'm almost positive that's the name of the facility. So we've got ED Care, Center for Discovery, and then Bellator. I believe they still at least have the evening intensive outpatient program. So those are the ones we have in Kansas City. Maybe we're going to be getting some comments about some that I missed. But looking for therapists who have a focus on eating disorders is really important if you're like referring your patient out to someone. If you call like an eating disorder facility that's local, they'll probably have a list of outpatient suggestions for you. I know at some of these, like I know for sure at ED Care, I'm assuming probably a Center for Discovery as well. They can do an assessment that's free and they'll help determine what level of care they may be appropriate for. And that is it. So I'll go ahead and stop my screen share.
Hey, that was wonderful, Rachel. That was a great presentation. Thank you so much. I'm going to let everybody know that this is being recorded and it will be available on the Mental Health KC Kansas City website. So if you need to see the slides and the presentation, you can access it then. I have just put in the chat the certificate that you can earn for attending today's program. And let's go ahead and address some of these questions. Is research psychiatric? Do they have an eating disorder?
As far as I'm aware, I don't think they do. I believe that they used to. I could be wrong. Um, I know one of the hospitals here in Kansas City used to have an eating disorder program. I don't believe that they do anymore.
Okay, if the person does not have hunger or thirst cues, is it still considered an eating disorder?
So it might fall in that category of like otherwise specified eating disorder that we talked about. Um, it depends on like how they got to that point. If they got to that point of no longer having hunger and thirst cues because of a long history of restriction that kind of just like deteriorated their metabolism, then yes, my guess in that case is that it's probably gonna fit in sort of like a gray area.
Okay, this is kind of a long one. Not to make this political, but I recently saw some discord around changes to body image beliefs and views associated with whomever is in major political office. Like there's more media influence to be thin when there's a more conservative administration versus more body positivity during a progressive administration. Are you aware of any evidence that reflects this, like an increase in eating disorder diagnoses when there's a conservative administration?
Um, it's not something that I've looked into necessarily, so there may be some research out there about it. I don't know any off the top of my head personally. That's interesting thing to consider.
Okay, do you have any recommended screenings for primary care?
Um, like eating disorder screening. Could you read it again?
Yeah, recommended screenings for primary care. I'm assuming that's eating disorders.
Hmm. Um, well, I don't know if I'm interpreting the question correctly. But there aren't a ton of really great screening tools, unfortunately, for eating disorders. There is one, I had it in my slides before. I'm losing the name of it right now. I have one that I kind of made myself that I use. But there's one called, it's like EAT is the acronym. Um, there's one other, I can't think of the name of it right now. I'll have to look afterwards and make an email them to you, Stacy. I know I had included them in the last presentation that I did with you guys. Scoff, that's what it is. Thank you, Rachel. Her name's also Rachel. So yes, that's the one that probably like the most common one.
Do you commonly see people struggling to get doctors or treatment teams to understand circumstances or be knowledgeable enough to provide appropriate intervention? And at what point are they expected to intervene when someone is showing signs of malnutrition but doesn't look like it? It's hard to type out these questions instead of verbalizing them. Is there a way to ask them beyond this webinar?
You guys can email me, and I can do my best to answer.
This is
Um,
in regards to a hospital setting.
oh, okay. Well, I don't work in that setting, so I guess I can't speak to it too much. I guess I'll try to answer like more like the first part of the question. So I do think it's difficult sometimes to number one, just like find doctors that understand eating disorders. I have a few that I will refer people to if they need a primary care doctor. I think that there's actually like a spreadsheet that I've seen shared before on some of my specific like eating disorder groups for different clinicians, but I do think that's really, if possible, like recommending them to a clinician who or to a doctor who knows about eating disorders is going to be ideal so that they do know when is this an emergency, when is this urgent. But yeah, I know I'm not fully answering the question, but I agree it's difficult. It's a difficult thing to manage, I'm sure, especially like in the hospital setting.
Is there a clinical difference between anorexia and orthorexia? It has always seemed to me that people identify as orthorexia because they want to avoid the stigma of anorexia.
Hmm. So, yes, there is a clinical difference. So, well, like I mentioned in my slide, orthorexia is not actually in the DSM, so it would fall under ARFID. So, there's a lot of differences between ARFID and anorexia. But yeah, I think because anorexia is like the most well-known eating disorder, probably, yeah, people don't necessarily want that, um, don't want to identify with it, maybe because then they have to like do something about it. Both of them are a problem. But yeah, there's definitely some clinical differences. Like with orthorexia, there's not as much criteria as there is for anorexia, especially from like a medical standpoint.
Okay, and this webinar will be available. It's recorded, so it'll be available on Mental Health KC website. So if you need to access the PowerPoint slides. Rachel, what is the earliest age to be able to diagnose ARFID?
Sorry, I'm answering. I just put my email there. Um, I would have to check the DSM real quick. I don't work with adolescents. I work with usually like almost 18 and up. So I would have to double check since that's not something that I run into typically.
Rachel, you want to put that in the everyone, you sent that to the hosts and
Oh,
panelists.
sorry. Let's see here. Everyone. Okay.
Let me just check here.
Somebody just asked about Graves' disease. I'm thinking that that might be autoimmune disorder, I'm not for sure. But I don't unfortunately have any experience. No, I haven't worked with any clients that have that. That seems really difficult. Somebody asked about any inpatient or residential programs that accept Missouri Medicaid. Unfortunately, I don't know of any, except actually, I feel like there's a case by case exception sometimes. I feel like it's always worth it to ask at the local ones. I think it all just depends on the finer details, unfortunately. Children's Mercy, yes, they do a great job with ARFID, especially. I've seen them work with that a lot. But yes, they do a great job with youth adolescent cases. That's a great point. Thank you for adding that.
Okay, I'm going to allow these people to talk. I'm going to allow Ruth Workoff to talk. Ruth, you have a question? Do you want to pose a question to Rachel?
Maybe she left. That's okay. No worries.
Okay, I'm going to ask Kara Dolan to talk. Kara, do you have a question for Rachel?
We made him wait too long. They're like, I forgot the question.
Okay.
But they have my email, so can shoot me an email.
Okay, great. Well, thank you so much. Thank you so much, Rachel. That was wonderful. We
Yeah, thanks
appreciate that.
everybody.
All right. I want to encourage you to attend our future webinars on the second and fourth Thursday from 12 to 1.
Awesome. All right. Everybody have a great rest of your day.
I will put that website where you can access these webinars.
Awesome. All right, I'm gonna go ahead and sign off.
All right. Thank
Alrighty.
you.
Bye, guys.